So now I'm going to discuss other much less common major neurocognitive disorders that can affect older adults. So the first one on this list is the progressive supranuclear palsy, or PSP, which is a late onset neurocognitive disorder characterized by selective tauopathy of subcortical structures in the brain. It presents with significant gait instability, axial extrapyramidal impairment, which means it affects the facial muscles, eye muscles, neck, back, and trunk before it affects the arms or the legs, significant executive dysfunction, and speech and swallow impairment. Two unique features of this type of neurocognitive disorder are the vertical gaze palsy and convergence insufficiency that you see in the eye movements, and also the wide eye stare, furrowing of the forehead, the frowning expression that you can see in this picture. Sphincter dysfunction can happen, part of the dysautonomia. So this disease affects only about 6 per 100,000 Americans. The onset is typically more than 60 years of age, and it tends to happen more often in men than women. The etiology is not exactly known, but some toxins have been implicated, like acetogenins, quinolones, and retinoids. The pathology is usually in the form of widespread tauopathy with neurofibrinoid tangles affecting neurons and tuft-shaped astrocytes, primarily affecting the basal ganglia, the midbrain, the frontal cortex, the limbic system, the dentate nucleus of the cerebellum, and the Onuf's nucleus of the spinal cord. So the diagnosis is usually based on history and exam. The MRI may show atrophy in the midbrain with a preservation of the pons, which is called the hummingbird sign. There are different types based on the pathology. So there is the classical PSP, which presents with the typical presentation that we just mentioned. There is the PSP-P, where the tauopathy is more restricted to the brainstem, exhibiting primarily Parkinsonian features, usually has a more benign course. There is the PSP with more cortical involvement, which presents with more FTD-like symptoms. And there is the PSPC, which is very rare, with a severe loss of the dentate nucleus of the cerebellum, causing significant impairment of gait. The prognosis is usually poor, and the mean survival is 7 years after diagnosis. The treatment is largely supportive, and levodopa and amantadine may help with Parkinsonism, but not much. So next on the same list is the multiple system atrophy, or MSA, which is a rare neurodegenerative disorder that's characterized by selective synuclein protein deposition affecting primarily subcortical structures, similar to how the Parkinson's disease dementia and dementia with Lewy body can happen, but more selective. It presents with severe autonomic dysfunction, vocal cord palsy, and recurrent falls. With the MSP subtype, you see more Parkinsonian features. With the MSAC subtype, you see more cerebellar ataxia features. And in both cases, cognitive impairment happens later in the disease course. The epidemiology is similar to how PSP presents. About 5 per 100,000 Americans, slightly more common in men, but it presents at a younger age, somewhere between 50 and 60 years of age. And the etiology remains unknown. So the pathology under the microscope for this disease shows neuronal cell loss that begins in the oligodendrocytes, which are naturally responsible for the myelination of the neurons, characteristic intracellular inclusions called the paplantose bodies, which have a different configuration than the alpha-synuclein that we see in Lewy bodies. So the diagnosis is based on the number of features that we have. So with a probable multiple system atrophy, we should see an autonomic failure involving urinary incontinence and significant orthostasis, plus either Parkinsonism that doesn't respond to levodopa or cerebellar ataxia. For a possible multiple system atrophy, you need Parkinsonism or cerebellar ataxia with at least one autonomic dysfunction and one additional feature, which are the vocal cord palsy or recurrent falls. The MRI is usually not conclusive. in these cases. So the prognosis is not so favorable. The survival is usually 5, maybe 6 or 10 years after the diagnosis. The mortality is usually related to the severity of autonomic dysfunction, causing infection and a failure to thrive, and ultimately death. There is no treatment, no cure. It's largely supportive, focused on rehabilitation and the management of the orthostatic hypotension, for which you could use either fludrocortisone or midodrine. So next on the list is the corticobasal degeneration, which is another rare tauopathy involving the cerebral cortex and the basal ganglia. Quite selective, huh? So it presents with an older age, usually above 60 years of age. A lot of motor symptoms including Parkinsonism, dysphagia, and alien hand syndrome, where the hand will move on its own. Cortical symptoms include idiomotor apraxia, kinetic apraxia, and non-fluent aphasia. May present with irritability and depression, and may show features of cognitive impairment similar to frontotemporal dementia. The epidemiology is similar to MSA and PSP, somewhere between 5 and 7 per 100,000 Americans, but this one is slightly more common in women, and the etiology is entirely unclear. So this one, as I mentioned, is primarily a tauopathy, showing ring-shaped astrocytic plaques in the affected tissue, as we mentioned, in the cortex and the basal ganglia. Diagnosis is quite hard and controversial. The most recent Armstrong criteria came out in 2013. For the MRI, and SPECT may show asymmetrical pathology in the posterior part of the frontal and parietal areas, may affect the corpus callosum, the thalamus, and the basal ganglia. The DAT scan is usually positive. The prognosis is poor, usually 8 years of survival after diagnosis, and the aspiration pneumonia is usually the most common cause of death. Treatment usually doesn't respond to many of the options that we might offer, and it's largely palliative at this point. Next on the list is the posterior cortical atrophy, or PCA. So this is a slowly progressive neurodegenerative disease that causes brain cell death that is more selective to the posterior parts of the cortex, disrupting visual processing. And some consider it as a visual variant of Alzheimer's disease. The presentation is usually a bit earlier than Alzheimer's, so it starts in the mid-50s to the mid-60s. It presents with visuospatial impairment, so reading and depth perception becomes a problem. A lot of apraxia, especially oculomotor apraxia, visual agnosia, and later in the disease it becomes very similar to Alzheimer's. The epidemiology presents around 5 to 15% according to study populations of Alzheimer's disease. The diagnosis, prognosis, and treatment is exactly the same as Alzheimer's disease, with more emphasis on occupational therapy, particularly for these subjects. Next is the normal pressure hydrocephalus, which is a form of communicating hydrocephalus causing the enlargement of ventricles, compressing the surrounding brain tissue. This one usually presents in individuals who are 40 or older years of age. It has a unique gait, which is broad-based, slow, short steppage, and kind of magnetic, as if their feet are like stuck with a magnet to the ground. 60% of cases will develop frontal dementia, which is characterized with executive dysfunction, impaired working memory, slow processing speed, and then you notice some apathy and non-fluent speech impairment. Up to 50% of individuals will have urinary incontinence. The diagnosis is usually based on the history and physical exam. The MRI is usually helpful, shows some unique features like the enlargement of at least one temporal horn, an acute callosal angle less than 90 degrees, and transepidermal edema within the brain tissue without evidence of obstruction. There is also the Miller-Fisher test, where you drain 50 mLs of the CSF and then evaluate later on. You should see some improvement. And the treatment basically is a VP shunt.